Hello everyone, this is Dr. Carlene Arraos and I will be discussing the essential intrapartum and newborn care. The EANC program is under the umbrella of the Maternal Newborn Child Health and Nutrition Strategy of the Department of Health. For our objectives, we aim to discuss the problem of maternal mortality and morbidity in the Philippines, to present evidence-based interventions that are recommended and are not recommended during the antepartum, labor, delivery, and immediate postpartum. There are too many mothers and newborns dying. Globally, it is estimated that each year, 500,000 women die from complications of pregnancy and delivery. 4 million babies 0 to 28 days old die every year due to prematurity, infection, and asphyxia. In the Philippines, the estimates are close to 5,000 mothers and almost 34,000 neonates die annually. Most maternal deaths occur during the labor, delivery, and the immediate postpartum period. This graph shows the causes of maternal deaths, and from decades ago until the present time, postpartum hemorrhage and hypertension are still the leading causes. Many maternal deaths are still due to bleeding, as we can see in the graph. For the algorithm on preparing for birth, this is what we usually do, especially in the primary health care facilities. Imagine yourself on duty at the health center or lying in clinic and an obviously pregnant woman comes in. The first thing that we do is greeting the pregnant woman and introducing ourselves. We also need to do a rapid assessment and look for emergency symptoms. If there's convulsions, headache, blurring of vision, severe difficulty of breathing, severe abdominal pain, and vaginal pain, we should always call for help. If there are no emergency signs, obtain the history, the current pregnancy, past pregnancies, check record, and birth plan. Next we do is by looking, listening, and feeling. We need to examine the pregnant woman by taking the vital signs, observe her response to contractions, checking the abdomen by doing the Leopold's exam, getting the fetal heart rate, duration, intensity, and interval of uterine contractions. If there is no bleeding, perform a vaginal examination to determine cervical dilatation, presence of bag of water, and the presenting part. Next, we need to determine the stage of labor, and if in the active stage and pregnancy is uncomplicated, admit and provide essential care within the facility. Otherwise, call for help and stabilize the patient and refer to the next level facility. The intrapartum care recommendations are based on the CPG on intrapartum care developed by the POGs using grade methodology in consultation with different stakeholders. Developed in collaboration with the DOH and WHO Philippines, it is an update of the DOH CPG on facility-based delivery and the POG CPG on normal delivery. Interpartum care refers to care of the woman during labor. The first stage of labor starts from the start of true labor to full cervical dilatation. Second stage occurs when there is already full cervical dilatation to the delivery of the baby. The third stage involves the delivery of the placenta. And the fourth stage is the golden hour or immediately the postpartum period. For the recommended practices during labor, when do we know a woman is in active labor? We need to admit the pregnant woman when she is already in the active phase. Since labor is divided into the latent phase, which may last for 24 hours, and an active phase, during which the cervix dilates approximately 1 centimeter per hour, the active phase labor is when there is 2 to 3 contractions in 10 minutes and cervix is already 4 cms dilated. Evidence shows that when women are admitted in active labor, there was less need for cesarean section and there was no difference in the Apgar score of the baby. Importantly, the need for cesarean section was decreased by 82%, while there was no difference in the need for labor augmentation or in the Apgar scores. It is recommended that women with uncomplicated pregnancies be admitted to labor when she is already in active phase. The presence of a companion of choice lessens the need for analgesics or anesthetics, resulting in a more alert baby who can breastfeed earlier and more frequently decreasing the risk for hypothermia and hypoglycemia. When we allow a companion of choice, we provide a continuous support during labor. It also lessens the need for analgesics, also less need for pain relief. This results in an alert mother and alert baby who is ready to breastfeed earlier and has decreased risk for hypothermia and hypoglycemia. Having a labor companion is not only mother-friendly, it is also baby-friendly by promoting early initiation and continuation of breastfeeding. For continuous maternal support, it means that the most important one-to-one intrapartum support from the mother's companion of choice and the health provider. It could be the husband, the partner, a friend, or a relative, or even a health provider. It includes good communication, respect for privacy, allowing the patient her position of choice during labor, allowing her to eat and drink, and providing adequate and timely pain relief. For the advantages of continuous maternal support, it increases the spontaneous vaginal delivery by 8%, while it decreases the need for instrumental vaginal delivery by 10%. It also decreases the duration of labor shorter by 1.5 hours and decreases the need for pain relief by 10%. And it also decreases the occurrence of 5-minute Apgar of less than 7 by 30%. So we should also recommend the position of choice during the first stage of labor or upright position and mobility. Most women admitted to labor are placed in the supine position, which, according to studies, is the worst position to be in during labor. They should be allowed to assume position of their choice, upright if possible. Women should be allowed to move freely during labor. There is evidence that walking and upright positions in the first stage of labor reduce the length of labor and do not seem to be associated with increased intervention or negative effects on mothers and babies' well-being. Women should be encouraged to take up whatever position they find most comfortable in the first stage of labor. So when we help the mothers position by upright, it decreases the length of first stage labor by about 1 hour and decreases the need for epidural analgesia by 17%. So these could be the different positions that we could teach the mothers in labor. Also, freedom of movement distracts the mothers from the discomfort of labor, release muscle tension, and give a mother the sense of control. So this is the WHO partograph that we use to monitor the progress of labor. Also, the number of vaginal examinations is related to the incidence of infection. Women who had less than 3 vaginal exams during labor were compared to those who had more than 3 exams, and it was noted that there was decreased incidence of chorioamnionitis and neonatal sepsis by 72% and 61% respectively. Among those who had less than 5 examinations, there was decreased incidence of UTI, although no statistically significant decrease in incidence of endometritis. Based on these studies, whether we use 3 or 5 internal examinations as the cutoff for restricted number of IE, limiting the number in a woman in labor results in a decreased risk for both maternal and neonatal infections. Vaginal exams to assess cervical dilatation should be done only every 4 hours or more often as necessary when the bag of water ruptures or when the woman is bearing down. For practices not recommended during labor, routine NPO is not recommended. No evidence of improved outcomes for mother nor newborn if on NPO. There is a very small probable risk of maternal aspiration mortality, and for normal low-risk birth, no need for NPO except when intervention is anticipated. Next is routine amniotomy to shorten spontaneous labor. There is evidence that amniotomy reduces the risk of dysfunctional labor by 25%. However, there is no difference in the duration of labor. It is also not recommended to give routine oxytocin augmentation. Should only be used by doctors when indicated and in facilities where there is immediate access to CS. Never use IM oxytocin before birth of the infant because its dosage cannot be adapted to the level of the uterine activity. So these are the different practices not recommended during the labor. Another one is the routine IVF. The advantage is to have the ready access for emergency medications. However, it interferes with the natural birthing process. It also restricts the woman's freedom to move, and it is not as effective as food and fluids in labor to treat or prevent dehydration, ketosis, or electrolyte imbalance. To summarize, in the normal uncomplicated pregnancy, this includes the process that was already discussed for the first part. And then next part is for the preparation for the birth. In preparation for the birth, ensure the delivery room temperature is between 25 to 28% to prevent hypothermia. Ensure that there are no air drafts. Discuss maternal and newborn care in the immediate postpartum period. Perform hand washing. Arrange instrument and other needs plus 0.5 chlorine solution for decontamination, and prepare the equipment needed as well as for newborn resuscitation. Next, prior to the delivery, we need to perform proper hand washing, don sterile double gloves, allow the mother to push as she wishes with contractions, and do not perform routine episiotomy. For providing warmth, we should always maintain the room temperature to be between 25 to 28%. Check for air drafts and turn fans and air conditioners off before the delivery. For hand hygiene, we should always practice hand hygiene before and after every procedure, as well as before and after handling our patients. It is the single most important method of controlling the spread of infection. It is very crucial that it is carried out correctly, at appropriate times, and by all health workers. So the different methods for hand hygiene includes hand washing, antiseptic hand wash, antiseptic hand rub, or surgical hand antisepsis. For hand washing, it is done when there is visibly dirty or visibly soiled with blood or fluids and lasts for 40 to 60 seconds. While hand rub is done when we see that the hands are not visibly soiled. There is access to hand washing facility. The access to hand washing facilities is not available, and it lasts for 20 to 30 seconds. So these are the 5 moments for hand hygiene. Before touching a patient, before a procedure, after a procedure or body fluid exposure risk, after touching a patient, and after touching a patient's surroundings. So these are the most frequently missed areas. Before hand washing, we should always remove all hand and wrist jewelry. So we do the hand washing by wetting hands with warm running water, apply soap and lather well, rub each area together counting 1, 2, 3, 4, 5, 1, by palm to palm, between fingers, back of the hands, base of thumbs, back of the fingers, fingernails, and the wrists. We should always remember that we shouldn't use artificial fingernails or extenders, no long fingernails, and gloving does not replace the need for hand hygiene. For the use of gloves, it reduces the risk of contamination of hands with blood and other body fluids. It also reduces the risk of spreading germs to the environment and of transmission from healthcare worker to the patient, patient to health worker, as well as one patient to another. So when do we use gloves? Before a sterile procedure, anticipation of contact with blood or another body fluid, and contact with patient during contact precautions. We remove the gloves as soon as the gloves are damaged, after contact with blood and other body fluid, broken skin and mucous membrane, and after contact with patient. So what gloves do we use? There are sterile gloves for surgical procedures and vaginal delivery, while the non-sterile or clean gloves is used for touching blood, body fluids, secretions, stool or urine, and items visibly soiled by above. If there is direct patient exposure, as well as indirect patient exposure. It is not indicated if there is no potential for exposure to blood or body fluids or contaminated environment. Gloves must be worn according to standard and contact precautions. Hand hygiene should be performed when appropriate, regardless of indications for glove use. For skin preparation and disinfection. So there are different types of injections that we use. So for intradermal, we need soap and water. For the subcutaneous injection, also soap and water. For the injections, also venous access. To disinfect the skin, we should apply a 70% alcohol, isopropyl or ethanol on a single-use swab or cotton ball. Wipe the area from the center of the injection site, working outwards without going over the same area. Apply the solution for 30 seconds and allow the alcohol to dry. We should remember to do that we should not pre-soak cotton balls in a container, as these may become highly contaminated with hand and environmental bacteria. We should also not use alcohol skin disinfection for administration of vaccinations. For the best practices in infection prevention and control, we should always do hand hygiene for at least 30 seconds. We should always use a pair of non-sterile gloves or procedure on a patient. We should always use a single-use device for blood sampling and drawing. We should disinfect the skin at the venipuncture site. Discard the used syringe and needle immediately in a robust, sharp container. Where recapping of a needle is unavoidable, do use the one-hand scoop technique and seal the sharp container with a tamper-proof lid. We should always remember that 1 in every 5 cell phones are found to carry infection-causing microorganisms. Some are even known to cause hospital-acquired infections. How dirty is your cell phone? It is said that a cell phone has 18 times more bacteria versus a public restroom. As you can see here in the petri dish, when the growth was seen that there are more bacteria found in cell phones than the toilet handle and toilet seat. Contamination rate by bacteria and other microorganisms are seen in cell phones at 96.5%, while 47% in stationary phones. It is also seen that 92% of the participants never clean their mobile phones, and the use of mobile phones in ICU may have serious hygienic consequences. So these are the recommended practices. Is the first, upright position during delivery. The anterior, posterior, and transverse diameters of the pelvic outlet enhances the fetal movement through the maternal pelvis in descent for birth. It also shows there is the efficiency of uterine contractions and improved fetal alignment. Also, we need to encourage pushing only when the mother has the urge to push. We do selective episiotomy if there are indications like need for instrumental vaginal delivery or vaginal breech delivery or fetal distress. Also, if there is shoulder dystocia or impending laceration. So for the diagnosis of the second stage of labor, for the traditional definition, it is defined by a fully dilated cervix, coached to push throughout a phase with her own sensation, while in the non-traditional, it is redefined as complete cervical dilatation with spontaneous expulsive efforts. Also, for the traditional, there's directed pushing, while in the non-traditional, there is involuntary bearing down. For selective episiotomy, it shows that there is a decrease in the posterior perineal trauma by 12%, second to fourth degree tears by 33%. It also decreases the need for suturing by 29%. Also, anterior perineal decreases the anterior perineal trauma by 84%, and there is no difference in infection rate with or without episiotomy. So when we do perineal support and control delivery of the head, we encourage the woman to stop pushing and breathe rapidly with mouth open, keeping one hand on the head as it advances during contractions while the other hand supports the perineum. This prevents the head from coming out too quickly and tearing the perineum. Use a pad on the perineum and discard it if it gets soiled. During the delivery of the head, encourage the woman to stop pushing and breathe rapidly. The next is use of prophylactic oxytocin for management of the third stage of labor after palpating the abdomen to rule out a second baby. So oxytocin is given to prevent postpartum hemorrhage. Before giving the oxytocin, we need to ensure that there is no second baby. So it decreases the postpartum blood loss of more than 500 ml by 39% and decreases the need for additional uterotonic drugs by 47%. So for the oxytocin during the third stage of labor, it when we give oxytocin, for the onset of action, it is at 2 to 3 minutes, while methyl ergometrin it is by 6 to 7 minutes. Oxytocin is the drug of choice in the active management of labor because it has a rapid onset of action. There are no known contraindications nor side effects. It is more stable when exposed to heat and light, and methergine has to be kept in refrigerator. So in this table, we can see that the oxytocin is better than the methyl ergometrin. Next is properly timed cord clamping of 1 to 3 minutes after birth or when the cord pulsation stops. It is said that when we do properly timed cord clamping or when the cord pulsation stops, it decreases the risk for anemia and also decreases the incidence of babies needing phototherapy due to jaundice. For controlled cord traction and counter traction, it decreases postpartum blood loss of more than 500 ml by 7% and postpartum blood loss of more than 1 liter by 24%. So controlled cord traction involves pulling with a firm, steady tension on the cord in a downward direction during contractions. Controlled cord traction helps the placenta descend into the vagina and facilitates its delivery. The uterus cannot contract efficiently if the placenta is still inside. The next is uterine massage after delivery of placenta. The fundal massage of the uterus after delivery is recommended even if no uterotonic is available. Massaging the uterus stimulates uterine contractions and helps to prevent postpartum hemorrhage. So we can see that uterine massage decreases the incidence of blood loss and need for uterotonics. So practices not recommended during delivery. Doing perineal massage in the second stage of labor. Compared to hand-off technique, perineal massage decreases third to fourth degree tears and there is no difference in first and second degree tears, vaginal pain, or blood loss. It has no significant change in intact perineum and occurrence of first and second degree laceration. Next is fundal pressure during the second stage of labor when we apply a manual force externally to the abdomen at the level of the uterine fundus to expedite the delivery. Although uterine rupture was not evaluated by studies, the CPG panel placed a high value on avoiding maternal injuries like uterine rupture and fetal death. So here in this slide, we can see that there's abdominal bruising related to fundal pressure applied. Also, there is vulvar edema as well as injury to the baby. For the care after delivery, it's recommended that we do routine inspection of birth canal for lacerations, inspection of placenta and membranes for completeness, and doing uterine massage and early resumption of feeding. We only need prophylactic antibiotics for third to fourth degree tears. And we should always keep the mother and newborn together. Not recommended is manual exploration of the uterus to expel blood clots and check for placental completeness. To expel the blood clots, we should just do uterine massage. Also, routine use of ice packs over the hypogastrium is not recommended, as well as routine oral or methyl ergometrin. For the immediate postpartum care, monitor mother at 2, 3, and 4 hours in every 4 hours. Advise on postpartum care and hygiene. Encourage the mother to eat and rest. Encourage the mother to empty bladder and ensure that she has passed urine. So the last topic is postpartum family planning. So we should always give the options for the breastfeeding woman. Immediately postpartum, we could advise on lactation amenorrhea method, IUD, female sterilization or BTL, and the use of condoms. When there's need to delay 6 weeks, there is progestin-only oral contraceptives, progestin-only injectables, and implants. And after 6 months, there is combined oral contraceptives, combined injectables, and fertility awareness methods. A breastfeeding woman can also choose any other family planning method, either to use alone or together with lactation amenorrhea method.